Hi guys, I'm going to talk about newborn hypoglycemia and basically any complications for the newborn. So we're going to start with hypoglycemia, SGA and LGA, which are babies that are small for gestational age and babies who are large for gestational age. So the newborn with hypoglycemia is basically diagnosed with blood sugar less than 35 milligrams per deciliter. So that's about 35 blood sugar, which is very low. Usually we're looking at about around 40 to 60 milligrams per deciliter, as you can see here. So, whoops, that's not what I meant to do. So, since we have a baby that's hypoglycemic, then we worry about some other stuff. So, one of the things that we worry about is usually some of the reasons why they're hypoglycemic is that if they still continue to be 35 milligrams per deciliter in less than in more than 3 days. Because if it's still 35 milligrams or around there, and they're only less than 3 days old, it's pretty much okay. But some of the reasons that this may cause is because of the hyperplasia in the pancreas of the mom, just the changes in the pancreas, and also maybe be caused by maternal overproduction of insulin. If the mom is usually diabetic, then she may produce a lot of insulin, and this causes a lot of hypoglycemia in the baby. All right, so other complications that we're going to look at is large for gestational age. So usually if the baby is over the 90th percentile, usually over more than 8 pounds, that's about 3 point something, maybe about 4 kilograms, you're looking at a large baby. And I've seen these babies, they're pretty big. One of the things that you're going to notice is that it's possibly because the mom also has maternal diabetes and the baby has had a lot of sugar from the mom that's causing the baby to grow. This can be kind of a difficult birth. Usually the doctors might use vacuum for a tool to try to get the baby out. And sometimes they use forceps too, but forceps, I guess from my teachers, says that it's not used as much. So now we have the cephalohematoma, and we've got the caput succedaneum. And the cephalohematoma is when there's blood in where the swelling is in the baby. And as far as the caput succedaneum, that's when there's edema, and that crosses the suture lines in the baby's skull. So it's just mostly kind of self-limiting. You can just tell the parents, hey, I'm sorry, your baby's head looks kind of weird, but it's going to resolve. However, if it is a cephalohematoma, then there is blood in there, and what happens is that some jaundice may occur, which is basically old red blood cells, and the baby can't really facilitate a filtering of those red blood cells, and it kind of interferes with the baby's spinal cord and neurogenic processes, especially because the baby has an open fontanelle, and it doesn't get filtered out by the baby very well, so it can cause some problems. So definitely want to look for that. Other problems with a difficult baby is a failure to descend. It's going to be pretty bad whether because the baby's pretty big. If the baby has also shoulder dystocia, which means that the shoulder comes first. Well, if it's failure to descend, like I said, they're probably going to use some kind of vacuum forceps or just go straight to C-section. With a baby who's presenting with the shoulder dystocia, then you're going to have to start doing the McRoberts maneuver, and what that means is that you as a nurse has to press down on the mother's suprapubic bone and try to tell the mom to get her legs up like in a frog position, and there you're going to try to push the baby out, or basically you're just going to get the help, and the doctor or the midwife is going to help you. So when you're doing the McRoberts maneuver, make sure that the patient's legs are flexed into the abdomen, causes a rotation of the pelvis, and then aligns the sacrum and opening of the birth canal. So it's kind of like a frog leg kind of a deal. We don't use stirrups anymore, but just make sure that you're pressing the suprapubic pressure applied and to the fetal anterior shoulder, because once that head is out, there's nothing. You're going to get that baby out, and the baby's got to come out. So you can't delay, and you need to know what you're doing. So make sure that you're watching over the mother, because the mother always comes first. If you can't take care of the mother, you won't be able to take care of the baby. Another thing I want to point out too is that you can see right there that there's a step 1 and then step 2 is how you're going to do that maneuver. All right, so cool. Moving on. And another thing we want to look at is for a fractured clavicle. And if your baby is a pretty big baby and you did the McRoberts maneuver, with the shoulder dystocia, you're going to be looking for a fractured clavicle, and you're going to be palpating the baby's clavicle to see if there's any fracture in there. All right, let's move back to where we were. And now let's look for small for gestational age baby. And usually, this is not macrosomic baby. It's not a large baby. Obviously, it's not macro, and it's not usually because the mother is diabetic. Usually, it can be for somebody who is a preterm, and they're just small for gestational age. What we're gonna focus on is on the size. So we're gonna be looking for a baby that's less than, let's say, 6 pounds. Pretty small baby. You can kind of tell. I'm not quite sure exactly what the exact poundage is. Hold on. Now I remember. It's baby who are smaller than the 10th percentile. So the baby that was larger for gestational age was somebody who weighed greater than the 90th percentile. So now we're looking at small for gestational age for babies less than 10th percentile of the average. And some of the nursing interventions you're going to do is that you're going to make sure that the environment is euthermic, so it's a good good temperature. So you're going to make sure that you check the baby's temperature, hopefully not just axillary, but also through rectally, if this is tolerated well. And so you're going to make sure that the temperature is not just working, but also the warmer and whatever that you're using to help keep the baby warm, or whatever you're using to help keep the baby cool, just make sure that the baby is within temperature. So you want to assess for fetal distress, decreased or elevated body temperature and any other physical abnormalities. Also check for hypoglycemia, because this is also a cause for it, from newborn hypoglycemia, as you can see right here. And you're going to look for ruddy appearances, signs of polycythemia, which is a lot of blood that are non-functioning. And you're also going to look for a ruddy appearance, kind of like what drunk people, like people who have been drunk for a long time, just a really red, ruddy appearance, like thick face. And also you're going to look for cyanosis, jaundice, or any signs of infection, as well as signs of aspiration of meconium. So while you're assessing, and now one of the other things that you're going to do for intervention as well is obviously to maintain the airway and the cardio function. You're also going to check for signs of respiratory distress, as well as monitor for infection and initiate measures to prevent sepsis. And you also want to monitor blood glucose levels and for signs of hypoglycemia. And initiate early feedings and monitor for signs of aspiration, as well as provide stimulation like cuddling for the baby. So that's what we were looking at here. So we're looking at babies who are small and large for gestational age. We're looking for newborn hypoglycemia, which is less than 35 milligrams, more than 3 days out of life. And the normal blood glucose that you're going to be looking for the babies around 40 to 60 milligrams per deciliter. And just remember, if you have a big baby, there's quite a few complications there. You've got the shoulder dystocia and difficulty birth. You're either going to be using tools or C-section, or if it's a shoulder presentation, then you do the McRoberts maneuver for the shoulder dystocia, and then you check for a fractured clavicle. Okay?